You obviously have put menopause under the spotlight. Mary Claire Haver.
Dr. Mary Claire Haver.
Why do you do what you do?
So many women have suffered in silence. Fatigue, weight gain, elevated cholesterol. These are really the major symptoms of menopause.
What is the average age for menopause?
Average age is 51 to 52 years of age. That means no more periods after 50 to 51. However, under that normal curve, and this is for fair people, that is 46 to 55.
I have no interest in having any more kids, but something made me sad, thinking that a day would come where even if I wanted to, I wouldn't be able to.
It was rare that a woman died or lived past menopause in cave people. We did have women living well into their 50s and 60s. They think it was for passing on wisdom.
How would I ensure that I make that easy transition?
So limiting alcohol, protein, and plant, because women are not getting enough of either.
Talking about hormone replacement therapy, I've had friends who have said that when they were in menopause, they were waking up once every hour.
When I forget my progesterone at night, I'm much more likely to have a middle of the night awakening.
When it comes to sex and libido,
Let her talk. And telling a woman to use coconut oil and lube is not the answer.
I would love you to talk to us about what is not going to give you cancer. Mary Claire Haver, welcome to A Life of Greatness.
Thanks for having me.
I wanted to start with a line that really stuck out to me that's in your book, The New Menopause. It is, menopause is inevitable, but suffering is not. Can you talk to us a little bit about that?
So when I came up through my medical education, I did 4 years at uni, then we do 4 years in medical school, and then we have to pick a specialty. So in my medical school education, I had 1 hour lecture and 4 years of menopause. 1 hour.
Wow.
And then in my OBGYN curriculum, I had 6 hours out of 4 years. So in 8 years, I had 7 hours of training in menopause care. I didn't know that it was much outside of hot flashes and the end of periods. I knew that our bones tended to deteriorate, but I thought that was more aging than menopause. I knew that the genital urinary system would go awry, but until those things happened to me, I was completely misunderstanding the whole process of menopause. And what I realized was this is not an optional thing. We all go through it.
Yeah.
But so many women have suffered in silence, in shame, in secrecy for generations. And once I truly realized the impact that menopause has on the whole body and that there are multiple things that we can do to alleviate suffering, that there's no reason a woman should walk into this process confused, ashamed. You know, this should be a celebration. This should be, we have a party when the 12 months goes by without a period, that you are now entering the best third of your life. And that is not what's happening.
I wonder why you wanted to get into obstetrics and gynecology.
Ooh. So in medical school, we do the first 2 years what we call didactic, where we're in classroom, we're just learning pharmacology and physiology and all the things. And then the last 2 years, we go through rotations in the different specialties. So we have family medicine, which is similar to GP here. We have OBGYN, internal medicine, which is like adult medicine in the hospital, and surgery, et cetera. So I really thought that I wanted to be a pediatrician, so to take care of children. And I did peds my first block, and I didn't love it. I thought, my gosh, I was the president of the pediatric interest group. Like, what am I going to do?
Why did you not like it?
I liked the children, but I didn't like their parents. You know, like I was struggling to like get the parents to, I just didn't see myself there, you know, and thank God that we get to practice before we pick, right? So then I think I did medicine and surgery and all these other blocks. I did OBGYN last. And so by the end of, that year, I knew I wanted to do something with my hands. I wanted to do something procedures, something surgical, but I didn't like general surgeons. They tend to be a very brusque, that's not my people. And then I rolled into OBGYN, and my very first night, I did labor and delivery nights and was catching babies all night long. And was crying and into the emotions and was like, I remember calling my mom and like crying, saying, this is it. I know what I want to do. I found it. I love the continuity of care that I would take care of a woman through multiple phases of her life. And it just made sense to me.
It's such a beautiful job, but I know that it's not often this happens, but it can happen that a stillborn will come along. How did you deal with that?
It's devastating. It's one thing when you're a resident and these are not your patients that you've cared for years. It's still devastating when I have the ultrasound and she comes in for no fetal movement or something, and I put the ultrasound on. I know instantly that this baby has not made it, And taking that deep breath to look her in the eyes and tell her that there's no heartbeat and the screams. No one takes it well, It is devastating. So then I go into private practice and I'm taking care of women through multiple, years and years and years. And now I have a relationship with her. Now I have to tell my friend that her baby didn't make it. And I mean, it's devastating. It's really one of the toughest things I've ever, that, and I've had one maternal death where woman came in, I did 9 months of care. We had a baby. She did great. She went home, and within 2 days she collapsed and died. And
Oh
so
my
I got called back to
goodness.
the hospital while they were, doing resuscitation, and it didn't work. And I had to go out and tell the family that she didn't make it. And that scarred me. That was, for the thousands of babies that I
Yeah.
brought into the world and the thousands of moms that I had shepherded through this process. Those sit with me still to this day. Occasionally I'll still be on a long drive and the memories will bubble up, and I'll just let myself go there and I'll just cry. Cry for those lives that were taken, And
It's
what
so
could I have
full
done
on.
differently?
Yeah.
What did I miss? All the what ifs, even though I know things happen and we're never going to always have a perfect outcome. It's still hard.
I know it's interesting, myself, I've got 2 kids. We understand that people have children. I mean, it's why we're here.
Mhm.
Birth happens, life happens, death happens. But when you actually are pregnant, you're like, I can't believe this. Like, this is incredible. And how a baby is
I grew a
formed.
kidney today.
It's
Yeah,
just-
you're
it
like,
is the most incredible part. But I think we often, because fingers crossed, majority of the times things do go right, but we forget those times where things don't go right. And we obviously feel the grief, hear the stories of the parents that go through having a stillborn or whatever it is. But we forget about the doctor on the other end who is equally as traumatized because they also have emotions and need to deal with it in a certain way. And I wonder for you, how were you even counseled on what to do if something like that happens, or given
so,
go to a psychologist after to deal with your own grief?
I really should have. So I had someone who was a close friend and was pregnant, and I got the call at 2 a.m. that she was in the hospital and they couldn't find the heartbeat, and she was due in like 3 weeks. Like, we were done. Like, if I delivered the baby the day before, the baby would have been fine. Okay. And I had to go in and, confirm that the baby had indeed, the heartbeat had stopped. And we diagnosed her with an abruption. So the placenta had sheared off the wall of the uterus. And then we struggled to get her into labor and ended up having to do a cesarean to deliver the baby. And the whole time I was like in a fugue state because, I had to just focus on the medical stuff. And she had a lot of complications. She had some medical things that made a surgery more difficult. I had to call in extra help, and, and then, as we delivered the baby, this would have been one of my kids' playmates, and he was so beautiful, and I just saw the life that he was meant to have and he never got. And yeah, I mean, the community rallied around her so beautifully, brought food, all this stuff, and I had to go back to work. But I had 3, 4 really good friends who came over and just let me sob and cry hysterically because it wasn't my death.
Yeah.
It was hers, and I didn't want to take away from her, but it was so hard. And I'll just never forget that night, those women sitting up with me all night while I just sobbed.
I think you do wonderful things. All, doctors are amazing. Obstetrics and gynecology is tough. You obviously have put menopause under the spotlight and perimenopause in such an amazing way. And it's very liberating for a lot of women having the information that you've really put a light to. I wanted to ask a question because it very much relates to me too. How do you know the difference between just premenstrual symptoms
hmm
and being in perimenopause?
So typically in PMS, it's very cyclical. So if you're still in premenopause, PMS is due to estrogen withdrawal and a bump in your progesterone. And for some women, that combination will lead to some pretty severe symptoms. But they typically are lasting 1, maybe 2 weeks of the month, and they're very, very cyclical. But when we cross into perimenopause, we lose that cyclical staging.
Ah,
So why perimenopause even happens is that females are born with all of their eggs. You have 1 to 2 million at birth. And by the time we're 30, we're down to 10% of our egg supply due to ovulation and due to something called atresia, just aging eggs. The healthiest eggs stay alive longer, right? And it's kind of survival of the fittest. So we have healthier children, right? Then in perimenopause, ovulation starts in the brain. We have a gland in our brain called the hypothalamus that's constantly testing for estrogen in the blood. So there's a little monitor, just imagine a little wire into
mm.
the blood supply saying, oh, estrogen levels are getting low as they do in a normal cycle, right after ovulation. Let's get the ovulation process going again. Well, in perimenopause, we reach a critical level of egg supply where the signals coming from the brain no longer work at the same level. So the brain gets upset. It was waiting for that estrogen. Estrogen's not coming on time. So it starts pumping out more and more stimulating hormone to the ovary to force that ovulation. So instead of that normal EKG-like rise and flow of our monthly hormones, we start seeing chaos. We start seeing much higher dramatic rises of estradiol, much lower crashes of estradiol, and progesterone never kind of gets, So it's literally what used to look like a beautiful, beautiful EKG. I take spaghetti and I throw it at the wall and it just, and that is what our hormones look like for the majority of perimenopause.
So if you're in
So,
perimenopause, do you still have, because I know people still have periods during
mhm.
that time, but are they not every month?
It
Like,
depends. Early perimenopause, you may still have a regular cycle, but the balance of hormones is changing because you're reaching your egg threshold. In later perimenopause, one of the hallmarks is the cycles start to become irregular, and that could be
mm,
skipping or having more frequent periods than you're used to.
that's so interesting. So are there any other symptoms of perimenopause that are different if someone's still having their period to a normal,
So,
person who was just having their period every month, got grumpy a couple of days before,
So
irrational?
we see an
Yeah.
exacerbation typically. If
Yeah.
someone had PMS, now their PMS is longer, earlier, less predictable than it used to be. So that's a
Yes.
trigger to me. Usually what happens first is fatigue. So when we really go back, so there's these new telemedicine companies in the US that are gathering data by the hundreds of thousands. Women go on, log in their symptoms, and they're keeping track of the data. And so forever, the cliche symptoms of hot flashes were what defined, classic menopausal symptoms. But what we know now, that's number 5 or 6. Fatigue, weight gain, elevated cholesterol, these are really the major symptoms of menopause. There was a wonderful paper that was published called I Just Don't Feel Like Myself
Mm.
as it relates to perimenopause. And it really is about 60 to 80% of women, that is their number one symptom. I can't put my finger on it, but I just don't feel like myself. They're losing resilience to the normal stresses in their life. Like nothing in their environment's changed. Same marriage, same drama, same stuff. But their ability to manage the life that they built becomes much more difficult.
Mm.
And that is one of the most common things that we see when we're really paying attention to the symptoms of perimenopause and not just automatically dismissing it as stress or weight gain or your bad marriage or whatever else. When we're really looking at, because we don't have a great test for perimenopause.
No, I've heard that you can't really,
Because of the
yeah,
spaghetti, doing the blood test that we use for
yeah.
post-menopause doesn't work. It's not
Mm.
applicable. Researchers are looking at using anti-Mullerian hormone, which is a fertility hormone, that to give you a gauge of where we use AMH for to see what your ovarian reserve is. Like, what's the likelihood you're going to get pregnant with IVF, right? Or on your own. But it also kind of gives us a clue of what reserve of your eggs are left. It's not great for perimenopause, but it's something. Consistently high FSH levels, which is a stimulating hormone coming from the brain. That's kind of a clue, but it's not perfect. A beautiful study just got released this month looking at a very specific LDL cholesterol molecule called small density LDL. And it goes up not with aging, but only with menopause. And so maybe considering using that as a marker to let us know that she's entering perimenopause.
And how long, because I know there's a lot of different figures thrown around and I know it is different for everyone. Firstly, what is the average age for perimenopause
great
and
question.
what is the length?
So for white women, Caucasian women, average age is 51 to 52 years of age of menopause, which is 1 year after the final menstrual period. That means no more periods after 50 to 51.
Yeah.
Okay. However, under that normal curve, and this is for fair people, that is 46 to 55 is still normal. Okay. We wouldn't get concerned to call it early or late if you're in that bubble. Now, if you're Indian, meaning from the Indian continent, not American Indian, that backs up to 46. The transitional phase, meaning the signals from the brain are struggling, is 7 to 10 years prior to the end of your periods. So women are struggling and dealing with this from their 30s until they die. So
what is the definition of menopause?
medically, it is 1 year after the final menstrual period. But what it means is something totally different.
Yeah, what does
What
it
it
mean?
really represents is ovarian failure. I hate to use it, sounds terrible. People get
failure.
offended.
Yes.
Ovarian retirement,
Yeah.
but you have run out of the eggs you were born with. There are no more and we cannot grow them back. So that is what menopause represents, the end of the egg supply in our ovaries.
You know, it's funny, when I was doing research for this interview, I was thinking about that, like going into menopause and the idea, I have no interest in having any more kids. I have 2 kids and that's enough for me and they are healthy and beautiful. But something made me sad thinking that a day would come where even if I wanted to, I wouldn't be able to. And I love what you mentioned before about how you shouldn't look upon it almost as a sad thing. It's this different era of your life. Can you talk a bit to that? Because I think people do think, oh no, it's menopause now. It's a downhill spiral.
So menopause, like being born with all of the eggs and living without your egg supply, right, is fairly unique. There's only a few species that it happens to. Right. It's not all mammals. It's humans. It's one pod of, I think, killer whales. A couple of giraffes, maybe, and maybe a dolphin, just a few of the really highly. But what the anthropologists are saying and the evolutionary biologists is like, why would this happen? Because when we look at the average life, when people died, it was rare that a woman died or lived past menopause. Mostly she died because a saber-toothed tiger ate her or disease or famine or, But say we cure all those things in cave people. We did have women living well, into their 50s and 60s, past childbearing. They were having kids at 12 and 13, though.
Yeah.
Well, 18. It depends on who you read, but, and they think it was for passing on wisdom.
Aww.
That the strongest tribes had the oldest women who were not babysitters. They were passing on how to survive. They were teaching the younger generations so that, they were the purveyors of wisdom, the crones. And I think that's kind of beautiful. And so this is our time to really lean into our wisdom. My kids are grown, 21 and 24. They're doing well, thank you, God. I don't have to worry about them. That I couldn't have done this 10 years ago when I was in the mother role. I couldn't have been traveling internationally and speaking on all these stages. And, that was not the life I'd built for myself. But now in menopause, I really feel like I'm living my best life. I get up, I'm happy every morning. I have better boundaries. I have better sex. I have better relationships. I have a better job. I built a life for myself that I adore. I'm educating by the millions. And I want every woman to get up and feel that way. And that's not happening. And had I not addressed my menopause and changed my nutrition, my habits, my exercise, really focused on what I want and not put everyone's needs in front of mine, I wouldn't be here today speaking with you. I wouldn't have written that book.
That's so interesting. I want to ask you firstly, for someone who, say someone like me that hasn't gone through perimenopause or menopause yet, how would I ensure that I set myself up well from a health perspective, that I make that easy transition? And
Sure.
then I'm going to ask you, once you're in it, what are the best things to do?
Okay. So we have to look at menopause and its effects on the body kind of in two ways. So we have what I call the fire of menopause, the menopause fires, where your ability to cope, your ability to manage your stress, your ability to manage the life you built for yourself becomes impaired. It could be from not sleeping. It could be from hot flashes. It could be from muscle and joint pain. It could be from brain fog. It could be from depression, right? All of those are menopause related.
Yeah.
So when my patients come to me, we have to put out the fires of menopause, and typically that's going to be hormone therapy, replacing the estrogen her brain is screaming for. Okay. Then we start, what habits are going to keep her healthy and keep her out of a nursing home? What diseases are plaguing her elders that she is desperately trying to avoid? So in my family, for me, it's my mother and my grandmother both had hip fractures and long-term nursing home care, from dementia. And I'm not interested in that. And that is not inevitable for me. But I have to really address the habits that it's going to take. I wish I would have started those habits at 35, right? Because it would have just been built into the system instead of overhauling everything. So limiting alcohol is one. Totally sleep disruptive, especially in menopause. You have to guard your sleep with your life.
Yes.
So getting good sleep habits, put the phone down, get the room cool, get the right sheets, get the whatever it takes for you to sleep your deepest, get a sleep monitor if that's your jam. That is key. Nutrition, prioritizing food that's going to make you healthy, not make you thin.
Like what food?
Protein.
Yeah.
Plants. I tell my patients protein and plants, especially on a GLP-1, protein and plants are like your top priorities because women are not getting enough in general of either. You're not getting enough fiber. You're not getting enough magnesium. We're certainly not getting enough vitamin D. So, I look at all we get a ton of blood work, right? We look at all their nutrition markers. We look at inflammatory markers and what can we do from a nutritional standpoint to really tweak that for her. Get her out of the mindset of eating to be thin. It's eating to have a bigger body, a stronger body, a body that's going to take care of you for the next 30 years because we have an epidemic of frailty in both of our countries. We have an epidemic of mother in the nursing home, but not dad. Why is that?
That's interesting.
Yeah. Why is it all the decisions in my family right now around the maternal care? My dad had a great life, a tough last month, gone, dead, done. We were all there singing, loving him. Done. This is a slog for my mother. She would not want this. She doesn't know what's happening, thank God. But, this loss of independence, this loss of and so what telling you now is what habits do you need to adopt? They may not make your hot flashes better. Maybe, but there's no guarantee. I have the healthiest people in the world who are absolutely flat out from their menopause symptoms, and that's okay. The trend is the healthier you eat, the more you exercise, you will have less symptoms, but it's not a guarantee.
Yeah.
But when we talk about the habits and what you need to do, we are talking about building a body that's going to kill it for the next 30, 40 years.
Tell me, when it comes to genetics, so for example, I got my period really early. I was 10. My mum was 10. And I asked her how old she was when she went through menopause and she was mid-50s. Is it genetically related? Like considering
Yes.
her and I got our periods exactly the same time, very early?
When patients ask me, when am I most likely going to go through menopause? I say, look at your mother, look at your aunts, look at your sisters. There's a huge genetic component to how many eggs you were born with and how long they're going to last. Now, there are habits that we can adopt, we know, or things that we can have done to us that will shave years off of the life of your ovaries. Smoking. Women who smoke go through menopause sooner. Abdominal surgery.
Oh, really?
Anything that causes inflammation in the gut. So women with autoimmune disease, with irritable bowel, with anything, because it's all sitting there together and causing trauma to the ovaries.
Yeah.
A hysterectomy, you lose 4 years, even though your ovaries are left behind. And lots of women have hysterectomies for very good reasons. But I don't think we're counseling patients as to the timing of her menopause and how that's going to be affected. So she's aware it can start intervening sooner.
And I wonder, does it make a difference if you did get your period earlier? Does that?
So we used to say no, but I just read a paper does
Of
now.
course you did.
So I'm a dork. I have a PubMed
love it.
alert on my phone every day when menopause or perimenopause is mentioned
Yeah.
in a brand new article, and I read every abstract.
Amazing.
I may not read every article. I look at the
Yes.
abstract and I'm like, okay, that's a good one. And this was looking at, and for years we thought, no, menarche, meaning your first period, doesn't really affect, but it does. It does. So
Is
maybe
it-
not a huge amount, a year or two, but remember, you're born with a set amount of ovaries. So if you start ovulating earlier, you're probably going to run out a little bit sooner.
That's interesting. And so I wonder, when it comes to actual menopause, what are people who are in it? What can they do to alleviate those symptoms? And you mentioned sleep, and that's obviously a huge one. Like, I know for myself, if I'm just worried about something and I'm lying there in bed
Anxiety.
and I can't sleep, I wake up the next day, and if you look at me the wrong way, I'll start to cry. Like, sleep is so important. And I know that you know him too. We were talking about him, Andrew Huberman, when I asked him, what's the best thing that you can do for your skin for, vitality and this and that? And he said, sleep. He didn't say put a cream on your face or anything like that. I've had friends who have said that when they were in menopause, they were waking up like once every hour. Why does that happen?
So 2 reasons. One is being woken up by the vasomotor symptoms, by the palpitations, by the hot flashes. Okay, that's one thing. My hot flashes are completely under control with hormone therapy. Then there's people who are waking up in the middle of the night, no hot flash, just that boom up, you're wide awake, and now your brain's spinning. It's some kind of an anxiety thing. And that seems to be something to do with maybe progesterone. And so when I forget my progesterone at night, I'm much more likely to have a middle of the night awakening. If I get up at like 2 and I don't take an extra progesterone, I'll usually spin out for about an hour and a half, usually with anxious thoughts or, every person whose feelings I've ever heard or every, mistake I've ever made, and just
It's so bad at that
running
time of the
through
night.
the drama, or
Yeah.
I can hear whatever noise is tapping in the background, So, but we know that, and now that we have so much data, so I'm working with Aura, the ring company.
Yeah.
They don't sponsor me, but I'm on their, I'm about to sign the contract to be a scientific
Amazing.
advisor
Yeah.
because I'm so interested in the data around sleep and menopause and like medications. So what meds are really interfering with sleep and helping? We know long-term use of melatonin, long-term use of sedatives leads to more dementia. It's not healthy.
Really?
Yes. So
Because people are obsessed with that melatonin. I've never taken it
long-term,
because
I don't know if it's the melatonin or people who
Yeah.
just don't sleep and they're taking melatonin because they don't sleep are going to have more dementia. I mean, this is how we repair our brain is with
course.
all the different phases of sleep. And so the thing about the Aura is it tells you the different, your light sleep, your deep sleep, your REM, all of that is important to rebuilding the resilience in your body.
Talking about hormone replacement therapy, you obviously mentioned that and that you're on it. And I know many years ago there was that scare that they said that
The Women's Health Initiative.
Yeah.
Yeah.
There's so much mixed information out there.
Right.
You are the specialist. I would love you to talk to us about what is the right thing to do. And I know every person is different,
Right.
but what works and
So
what is not going to give you
for
cancer.
the vast majority of patients, especially if they start close to the onset of their
Yeah.
menopause, hormone replacement therapy in the form of an estrogen plus or minus a progestogen is massively safe and incredibly protective in multiple organ systems. It will always protect your bones. It will prevent osteoporosis and fracture in about 50% of cases. It will protect your genital urinary system, therefore preventing recurrent urinary tract infections, vaginal dryness, painful sex, the complete a woman today was telling me a story about her mother who told her in tears, who had been denied hormone therapy because of a history of cancer and denied local hormone therapy, which is perfectly safe for everyone. And she said, my vagina's completely disappeared. And this happens,
do you
complete
mean?
atrophy, the labia atrophy, everything goes
Like
away.
it
It
shrinks?
shrivel. Yeah.
Really? I never knew that could happen.
Looks like a newborn. So yes, absolutely happens. And if we, it's totally treatable. It does not have to happen. We have perfectly safe medications that, 99.9% of women can use to protect their genital urinary system from this happening. And this is just a conversation because of the shame and the secrecy and the hush hush, and we don't talk about these things. We have created women who are living in misery and silence. But guess what? Gen X, They're not having it. I'm not the
Yeah.
movement. It's you.
Yeah.
You are like, absolutely not. I am not going to allow this to happen. I want to know all my options. And you may or may not choose hormone therapy. I don't care. But you're not given the option and you're not given the right information. And that's the problem.
When it comes to hormone therapy, what is it exactly like? From what I know, it's a patch.
So let's talk about it. Let's talk high level.
Yeah.
So we have estrogens.
Yeah.
Right. We have progestogens.
Yeah.
And we have androgens, which you would think of as testosterone. Right. So we have human hormones, sex hormones are estrogens, progestogens, and androgens, usually in the form of testosterone. Estradiol is what our ovaries made. Okay. Estrone typically is made in the periphery, like in fat cells. We have something called estriol, which is the pregnancy hormone that is made in the placenta. And then, but it can be formulated and is used to treat, like I use estriol on my face. And then we have esterotrol, which is the fetal estrogen that is made in a fetus that they've been able to formulate as well. That's used in, I think, a birth control pill. I don't prescribe it, but it is available. So then we have our estrogens, right? Most of us in the menopause use estradiol. We're just trying to give you back what you're missing.
Yeah.
Right. And so how do we do that? We have oral and non-oral forms. Okay. Oral, everything we ingest orally, food, medication goes to the liver for processing once it gets through the gut. Okay. When that bump of estrogen hits the liver, you see a very slight elevation in clotting factors. So for a woman who's prone to blood clots, you have an increased risk of a clot. If we avoid the oral formulation, we can cut that risk to her baseline.
Oh, wow.
So for that reason, lots of us choose a non-oral formulation first. So that could be a patch, a cream, a gel, a troche, a vaginal ring. In the U.S., I only know the U.S. formulations.
Yeah.
I think they're similar here. So that's your estrogens. Progestogens are the synthetic progestins or natural progesterone. Progesterone is a humongous molecule. It doesn't pass through the skin very well. So the creams are kind of variable. I don't like, most of us in the menopause don't use progesterone creams because we're worried about penetration and not giving her enough to protect the lining of the uterus. Okay. There's variable absorption with estrogen topical stuff. So some women need a little bit more. So I love the oral progesterone, one, because you can take it at night. It elevates GABA in the brain, which calms everything down. And you sleep much, much better. And last night, they were like, Chris is struggling with jet lag. And so the women at the table were like, give him one of your progesterone, see how he does it. He makes progesterone on his own in small amounts, but, it won't hurt him. And I was like, honey, do you want to try it? And he's like, no. I'm a little scared. So anyway, and then we have our androgens, which is testosterone. Similar to estrogen, we try to avoid oral formulations. Now, here in the UK, I think you could get undecanoate, which skips the liver for processing. It can be liver toxic. So in the US, we use mostly topical forms of testosterone. Creams, gels, I use Androgel or Androfem, the equivalent in the US quite a bit.
It sounds like, I know, again, everyone is different, but HRT really is the way to go. It just sounds...
I think every woman deserves a conversation.
Yeah.
And, not just limiting the conversation to hot flashes, no hot flashes, and only for severe and only the smallest amount. Where the conversation I think is lagging is the prevention. The prevention of, don't you want to protect your bones? What's your bone density?
Yeah.
Let's get a baseline bone density. Where are you at? Talking about, we know that from the data, though it's not recommended yet. I think it's coming from the preventative task forces, but we know that women, we have a window of opportunity for heart disease. Estrogen is wonderful for no one's going to argue with me on this. I don't care what society. We know the data is clear. Women who are given hormone therapy early in their menopause have less heart attacks, less death from heart attacks, and less all-cause mortality. The data is clear.
Do you know something really interesting?
You have to start early to get that cardiovascular benefit because it's better at prevention than cure. Once the plaques form and the plaques are calcified, it's not helpful and it might be harmful.
Wow.
So,
I was looking up the other day only because a friend of mine had told me this fact and I wanted to make sure it was true. On the Australian government website, and I would think this was similar like in a lot of countries around the world, that women from the ages of 45 to I think it was 75, the number one cause of death is heart disease.
Yeah.
I thought it was cancer.
No, it's heart disease in the US as well.
And then it goes into dementia and Alzheimer's and stuff like that. I could not believe that.
The number one killer of women is cardiovascular disease.
Because I feel
we do much poorer. A woman is 50% more likely to die from a primary heart attack than a man. Do you know
Really?
why?
Why?
Because we have a gender health gap. The meds were tested on men, by men, for men, and women were not included in the studies. They were excluded in the U.S., which is where most of those studies were done for
Yeah.
statins and whatever, until 1994, because they were worried about harming a fetus. So if a woman even had a potential of being pregnant, if she was of reproductive age, she was excluded from studies. So we don't know. So the meds work much better for men. The outcomes are better for men. The way we describe a heart attack is for men. Women have diffuse microvascular disease in their hearts. Men have the widowmaker, the very close to the aorta where the vessels come out. They get the plaques in the very top part. Women, it's further down, deeper into the muscle bed. So the way we feel pain when those tiny vessels start acting up is fatigue, abdominal pain, very vague. Okay. A woman is much more likely to be blown off, misdiagnosed, or given anxiety medication while she's having a heart attack.
Oh my God.
Because atypical chest pain is how we describe 51% of the population having a heart attack as atypical.
Yeah. And numbness on the side.
That's
or
men, not women.
That's what I thought.
Yeah.
Wow.
Going up the neck, da-da-da.
Yeah.
Grasping the heart. That's men, not us. So we have a gender health gap where women are living longer than men. All the wellness bros and the ice baths and the red light therapy. If you're not talking about menopause in women, you're missing the conversation. We win. We live longer, 3 to 4 years. That's not that's a huge amount.
Yeah.
But we're living 20% of our precious lives, 20 to 25, in poorer health than our male counterparts.
Wow. You just said something, and I would have forgotten to ask you this. I'm happy you brought it up. Ice baths.
Mm-hmm.
What is are they?
Don't even talk to me about that until you're on HRT. If we're going to talk about longevity for women.
So is that something that, because I've heard it potentially is not
I have
that
Raynaud's
great.
phenomena. There's no way I'm getting in an ice bath.
But from a health perspective and knowing the woman's body, is it a good thing to be doing or not?
I have to go see what Stacey Sims says about that kind of stuff. To me, she's the guru of,
yes,
is
that
that stuff
kind of,
even reasonable? Because she really teases out the data for women.
Yeah.
And, right now, I'm just trying to get everybody educated about menopause. I don't have time to look at ice baths.
Yeah. No, that's very
and
interesting.
I am not interested in getting in one.
Yeah, neither. I want to ask you, as far as nutrition is concerned, for someone like you that obviously knows so much about this area, what do you typically eat in a day?
So I am also, I've shifted my focus from thin to strong.
Yeah. Which
forever,
is wonderful.
forever. I was like, I'm thin. Look at me. I'm amazing. I'm so healthy. I'm thin. I got on that scale every day. I lived and died by that scale. I don't do that anymore. I am trying to eat to grow. I want muscles, and I want strong bones and a strong mind and strong muscles. And when I think at 35, if I would have gained 10 pounds of muscle, I would have felt horrible about myself. I would have felt fat. I would have said all the negative things in my head. And now I beg and scream and cry to try to grow muscle. I'm constantly in the gym lifting because that muscle is going to protect me from diabetes, protect me from dementia, protect me from frailty, protect me from falling, so that my kids aren't going to be struggling with the end of my life, which is no one wants that.
So do you eat a lot
So
of
what do
protein?
I eat much more protein than I used to. I
Yeah.
probably was eating 50 to 60 grams a day, which is pretty typical for a woman. And now I'm focusing on 100 to 120. So how do I do that? So I supplement. So I have, I will make a shake most mornings that has Greek yogurt, plain Greek yogurt, hemp seeds, flax seeds, and chia seeds. So I'm getting protein, I'm getting fiber, I'm getting omegas. I put berries. I love berries. I love the tang and the flavor. And that also gives me extra fiber and anthocyanins. So, and then I will add a scoop of creatine, and I'll put whatever protein powder I'm jamming on that day. So vanilla or chocolate typically. And so that will give me probably 50 to 60 grams of protein in that one meal. Now, I don't just sit there and pound the whole thing. I make a giant thing of it, and I will sip at it the whole morning while I'm working out, while I'm working. It'll take me 2 or 3 hours to get through it.
Yeah.
Then I'll take my supplements. So for me, I don't recommend this for everyone, but I'm taking a vitamin D. That's a vitamin D, omega-3, and vitamin K combo. This is one that I create, and it's, I sell this in the U.S. I will mix up my collagen drink, and I'll sip on that while I'm taking my supplements, and I'll take my probiotics as well. If I'm having hip or back pain, I'll take a turmeric that day. I've been experimenting with berberine, but with the berberine, my cholesterol had gone up, right? And so not super high, but for me, it was outrageous. And so, and my ApoB was also elevated, another marker of potential for cardiovascular disease. So I got really focused. So I upped my fiber intake to 45 grams a day. So one of the things I supplement is fiber. So once a week, my husband and I will make a big pot of beans and we'll add tons of ground turkey or whatever lean meat we have, chicken, and we will have that as meal prep and then add that as a side or take it for lunch or whatever. And I can get 20, 30, 40 grams of protein in that as well. So I always have things kind of ready to go. I love the dried edamame
Oh, yum.
beans.
Yeah, they're delicious.
And with the
So they're
different
good for you.
flavors.
Okay.
So 12 grams of
Yeah.
protein with another 10 grams of fiber. So I'm like just constantly like
Yeah.
looking for tricks and ways to get the
And
protein
nuts
the
and
fiber
things
in.
like that, are they?
Yeah, nuts are high in good fats,
Yeah.
high in fiber, typically for depending on the nut, and high in protein as well.
And fruit?
I love fruit. I eat fruit all day.
Yeah.
So, for me, it's the flavor, the crunch, the immunity, from it. I'm not worried about I don't have any risks of diabetes. I got my A1C under control. My HOMA-IR scores back down to normal. I kind of went through, my menopause transition was tough. And I had multiple markers just going up, 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 up. And I was always healthy because I was thin,
Yeah.
right? And so totally rethinking, relooking, and building my muscle mass has really turned this around for me.
And carbs and sugars.
So I try to limit my added sugars, things added in cooking and processing and alcohol, to less than 25 grams a day. And if I can do that consistently, I'm fine.
Yeah.
So I have the occasional cookie or treat or
Yeah.
birthday, whatever, but it's not like a normal part of my day.
Yes.
If I want something sweet, I'll have fruit.
And do you drink alcohol?
I do.
Yeah.
Much less than I used to. It's much more rare. It's so sleep disruptive. So if I
So
choose,
sleep
if I go out with
disruptive.
my girlfriends
Yeah.
or something, but like a glass of wine with dinner is not our usual anymore.
Yeah.
I can't manage it, and I'm giving up sleep. And I know if I give up sleep, I'm opening the door for dementia, and I'm not willing
Yeah.
to do that.
I'm exactly the same when I have I do have a drink here or there, but I
Mhm.
know if I'm doing it exactly the same as you, the disruptive sleep, the next day feeling down in the dumps, I don't know if I want to feel like that.
Right.
You know?
It's a choice, and
Yeah.
I'm choosing not to sleep well.
Yeah.
So
That's so interesting. And I wonder as well, obviously exercise is important and you talk a lot about building muscle. You're
Mhm.
always in the weighted vest.
Ruck Vest, it's a company
Yeah.
here. He dropped some off at the hotel.
Oh.
So Kelly and I went for a walk today, Kelly Casperson, and we had our weighted vest on and we were walking under the bridge.
Oh my
and,
God, I love
we
that.
took pictures in front of the Opera House in our weighted vest. So
For anyone that's not watching the video, no weighted vest today in
No.
the interview. I think that's wonderful. Talk to us though, how much exercise should a woman who is in menopause be
Yeah,
doing,
great-
and like
great
heavy
question.
weights or
you need to be doing progressive load. So heavy
Yeah.
weights, heavy. Okay. We don't respond as well as we used to in our 20s and 30s. And you have to have enough amino acids on board to feed that muscle. And creatine is really helpful. Like those three things are synergistic. 2 to 3 days of lifting and lifting heavy. And so you don't need a lot of complicated movements, squats, lunges, pull-ups, push-ups,
Yeah.
And so I have a trainer who makes the program for me, and she's in New York. And so she every month sends me a new set of exercises so I don't get bored. So I do that. And then 150 minutes a week of cardio seems to be the sweet spot or more where we have the most cardiovascular fitness. So it should be a combination of what we call zone 2 training, which is you can walk
Yeah.
and talk, but the talking is hard. So that's the amount of work. And with the smartwatches, like mine will tell me when I'm in zone 2. But then you should probably, a couple of times a week, do a few sprints. You need to run flat out or, get on the bike or whatever, where you're really pushing and kind of that Tabata style
Yeah.
for, 10, 20 seconds, 5, 6, 7, 10 times. You don't need much. And that a couple of times a week seems to be the magic where we're seeing a lot of benefit.
And for people, I've heard a lot of women say this. So where they, and you know this from people showing up at your doctor's office, who feel like they're going mad, like they legitimately feel that they've gone mad. Why does that happen? And then is it HRT that helps that?
So the mental health changes we see at least, and the data is actually coming out of Australia is excellent on
good.
looking at perimenopause and mental health. We see, so look, before we recognize perimenopause for what it is, right? we know that the rate of SSRI use, of antidepressant use, doubles across the menopause transition.
Wow.
It goes to 1 in 4 women will be on an antidepressant.
That's sad.
1 in 4.
Yeah.
So, you know, is no one curious why this is happening? Like, why are so many women suffering that we need medication to change the neurotransmitters in their brain? You know, I love having access to SSRIs. My patients tend to do well on them. But, most women we know from the data coming out of your country is that women who develop new or worsening mental health disorders and anxiety or depression will do better with hormone therapy than with the traditional medications. So we were not treating the sudden surge that we see, the 40% increase in mental health disorders, with the right medication.
Wow.
They need estrogen to stabilize their brains.
And how long do you stay on something like that? Is that forever, or is there
Potentially. So as long as for the patient, she wants to stay on it, the benefits outweigh the risks for her, and she's happy, she can stay on it forever. There's no age at which you must come off.
And how long is that when you go through menopause? How long does that last? Like, obviously, you were then in it, but
So forever we defined menopause as hot flashes, right?
Yeah.
The vasomotor symptoms. So you were menopausal when you were having hot flashes. And I just saw Paulina, she tagged me. I was like, Paulina Porskova just tagged me. In a video talking about her menopause and why she never talked about it. At the time she was menopausal, like having terrible symptoms, she was also going through a divorce and then
Yes.
the illness and death of her then, husband, ex-husband, who she took care of. Well, very difficult on top of layering all the emotional stuff. She's, I've never talked about it because it was so traumatic and I can't tell you which was caused by what. And I really appreciated her honesty and candor there. But she says, but I'm through it now. So her obvious symptoms are gone. Her bones are still taking a hit, I promise. Her, cardiovascular system, like her cholesterol, is most likely still struggling from the loss of estrogen. We just never taught her or the rest of the world that all of these things are related. When we talk about one of the critics there was a really famous article that came out last year in The Lancet, authored by one very prominent OB-GYN here in Australia who, I'm not going to say her name out loud, but, and I led the rebuttal to that article. And
what
so,
did she say?
So basically that one of their tenets is we're over medicalizing menopause, that rushing. Now, right now in the US, only 4% of women, 4, 1, 2, 3, 4, who are eligible for hormone therapy are on it. So we have 96%. I don't know what the numbers are here, but it's not great. It's less than 10%. Okay. So we have 90-something% of women who are raw dogging their menopause. And we're being accused of over medicalizing menopause. Okay. So here's what actually happens. A woman goes to her doctor and she has sleeplessness, weight gain, depression, itchy skin, all these things. She gets palpitations. Classic symptom, 43% of women will have palpitations in menopause.
Oh, God.
So she goes to the cardiologist, she gets a beta blocker for her palpitations. She gets a sedative for her, she gets Ambien for her sleep. She gets, she gets 4, 5, 6 medications to treat each individual symptom of her menopause. But she doesn't get hormone therapy because that would be over medicalizing, yet she's on 6 medications. What is the over medicalization? It is the failure to recognize and treat menopause by the root cause and replace the estrogen. Give her one medication that's just giving her back what her ovaries used to make, so she feels better and her life is better and her quality of life dramatically improves.
If someone feels like they need information, they want to go to their doctor because either they've got menopause symptoms that they, want helped, or they want to talk to someone about perimenopause, whatever it is. What is, because I know a few of my friends have had this, like, who is the best doctor to see about this? Like, who has
Someone
the
who
information?
Well, we are not training our clinicians. Like as I said, I had 7 hours. I had to go outside of the box and educate myself. In the U.S., we have the Menopause Society, and I'm a certified. I took the test, took the test and got certified as a provider. That's one way, is to, you really have to dig. It's kind of the Underground Railroad in most countries to find someone who has chosen to educate themselves about menopause, because we're not doing it in our traditional training programs.
And I think people struggle with that. Like they
Mhm.
find it hard to find someone that has, or, maybe there are people out there saying they have, but who knows what kind of information
That they've
that,
gotten.
yeah.
So that's a huge problem, and it's worldwide. It's not just the US or Australia.
I wonder, you mentioned weight gain. Did that happen? I mean, clearly not now, but did that happen to you?
That's really what drove me into this
Yeah.
space was I'd had thin privilege my whole life. I'd gained weight with children. It came right off.
Yeah.
All the tricks and things. I was able to kind of maintain my little tiny figure, not knowing I was sacrificing muscle and bone in order to stay tiny.
Yeah.
And then all of a sudden I was, I went through a depression from my brother's death, and I attributed the weight gain to that. And then as I felt the depression fog start to lift, the grief lift, I was like, okay, time to get your body back, right? Let's go back to your little tricks. And nothing was working. Like I was increasingly frustrated. I was getting up to pee in the middle of the night because menopause, and weighing myself, after I pee. I became obsessed, and I was working out twice a day. I was calorically restricting to like 900, like dangerous levels, like ridiculous. But I was like, this has to work because this is what I've been told my whole life and what I've told my patients.
Yeah.
And it is not working for me. And I could just hear the years and years of patient complaints of the same thing over and over again, and me just patting them on the knee and saying, work out more, eat less,
Mm.
And then when it was my turn, I flipped out and called the PhD nutrition department at the university I was employed at. I was like, what's happening in menopause? It's me. And they're like, well, here's some articles. There's some new information coming out about inflammation. I'm like, inflammation? They're like, yeah, the loss of estrogen seems to be causing systemic inflammation, and that's starting in the insulin resistance markers go up, and the cholesterol's going up, and it's driving fat to the abdomen. And I'm like, is that what's happening? Because my belly was bigger all of a sudden. I call myself Miss Potato Head because I have like the round body and the tiny arms and legs. And the potato part was getting bigger. And my cholesterol was going up, like all these things were happening. And I'm like, I can't live. What have I done? What am I doing differently? So that kind of led to, my frustration with my own cosmetic appearance led to all of the research and everything that I read and be, oh my gosh, we're doing this wrong. It's not just about, calories are important, but the quality of your nutrition, anti-inflammatory approach, really making sure you're prioritizing protein and getting into building muscle. It just, everything shifted. And then I started talking about it on social media, and the world exploded.
Wow. With collagen and skin, do you find that people that go through menopause, I think I actually have read this, the collagen and elasticity of the skin changes?
It's by biopsy, you will lose 30% of your collagen within the first 5 years of menopause.
And so is there anything that people can do about that?
So my derm friends are the ones who told me about this. You can use topical estrogen and you can attenuate that. Nothing is better than your 25-year-old ovaries, but that ship has sailed,
Yeah.
right? So, no one's transplanting those back into you
Yeah.
to give you another 25 years.
Yeah.
So topical estrogen has some reasonable data, and they were doing great studies before the WHI. And then, look, when the bomb dropped from the Women's Health Initiative and they scared the whole world unnecessarily, saying estrogen causes, you will get breast cancer, you will have a stroke. None of that is true. Everything stopped. All meaningful research in women's health after reproduction ended.
Wow.
So then it started picking back up in the last 5 to 10 years, and they've done studies. So topical estrogen is one way, but you should be wearing all our listeners, please wear sunscreen. That is the most important thing you can do for your skin. Hydration, good skincare. It all works together. I do everything,
Yeah, you have beautiful skin.
Thank you. I've done the CO2 I just did CO2 laser resurfacing. That was a gift to myself when I turned 56. Highly recommend. Very painful, but really, really helps stimulate collagen. I do topical estrogen. I eat right. I sleep. I prioritize, all the right things, and it all kind of works together.
Yeah.
And I wear sunscreen like a crazy person.
Do you?
Mm-hmm.
And especially here in Australia,
Mhm.
the sun is full on here.
Yeah.
And the ozone layer is not very good here either. I wonder, when it comes to sex and libido,
Mhm.
that's obviously
Yeah.
something that people don't like to talk about as much because they find it embarrassing.
In my clinic, when I was doing traditional OBGYN, we have the well woman exam, right? The
Yeah.
yearly annual. So we do the PAP. How you doing? Everything's fine. And as I'm walking out the door, I put my hand on the handle, and she'd say one more thing. And I just knew what was coming. And 9 out of 10, it was, I'm really struggling. And however she would put, with her libido, with sex, I just don't want it anymore, whatever. And I would sit down and let her talk. And it is greater than 50% of the population, and it is causing, and then so we have kind of 5 buckets as to why a woman, and no one taught me this, by the way. I didn't learn this in medical school. I did not learn this in residency. I learned this from Kelly Casperson, from the Menopause, from surrounding myself with experts. She's a urologist, right? She's here for the conference. And so in the 5 buckets, we have relationship disorder. If you don't like your partner, I am not going to be helpful with that.
Exactly.
So we talk about, do you love this person? Do you want to be intimate with them? Okay. We have a pain problem. So atrophy, like we talked about earlier, you lose the architecture of the vagina. You lose the ability to make mucus. You lose the elasticity. Things start shrinking. It's very painful. That's a normal response to not want to do something if it hurts, okay? And telling a woman to use coconut oil and lube is not the answer. We want to restore the health in the tissue of the vagina, and that's vaginal estrogen, okay? So I don't even talk about libido until we stop the pain, okay? Then we have arousal disorders and we have orgasmic disorders. So arousal is the physiologic response to a stimulus, okay? Brain says, woohoo, let's do it. Then you start pumping blood to the area, mucus production happens, blood flow. Some women really struggle with that from diabetes, from nerve conduction disorders. So there's, actual vaginal Viagra works well for that. Then we have orgasmic disorders. Do you know that 10% of women will never have an orgasm in their life?
Really? Just generally, not through menopause, not because they're going through menopause.
That's secondary anorgasmia. Primary anorgasmia affects about 10% of women. If that happened to 10% of men, it would be a world emergency.
Wow.
It would be cured, right? I mean, but women, we don't talk about it.
Most women, not most, but a lot probably don't even know what a orgasm is, because we hear so much about what happens. It's more obvious with a male.
Or they watch pornography and they just think, you put something in a place and woo, and that is not what happens at all, And so we have a lack of education around our own anatomy that is contributing to this. And then we have desire. Desire is what happens in the brain. And that is what most of my patients have, is that they have a good relationship. They used to have what they thought was a good desire. They miss it. So Kelly and I were talking, is there an evolutionary advantage to losing the desire to have sex? Like, is it protective somehow? Like that's a whole sociological question. But so my patients are coming in saying, help me. I miss the intimacy. I miss that drive, that desire to want to be intimate with my partner. Can you help me get it back? And I say, maybe. So we have 2 classes of medications that can be helpful. We have testosterone, which is, no one will argue with you. The data is clear, is helpful for women. Not all women, but it can be helpful. Then we have 2, in the US, we have 2 FDA-approved medications. One is called Addyi, A-D-D-Y-I. It's a pill you take every day. It helps with mood. It helps with dopamine. And when dopamine levels are higher, we want to do things that are pleasurable.
Yeah.
And then we have Vyleesi in the US, which is an injection you give yourself 45 minutes before, causes melanocortin release, which stimulates dopamine, which makes you want to have sex. So we do have options in the US to help with this, but most women don't even know. Everyone knows about Viagra.
Yes, seriously, everyone knows about it.
And the 9,000 others that came after it, right? There's, I think, 17 different FDA-approved medications for male sexual dysfunction. Female, we have 2. Testosterone is not approved for women in the U.S. You guys, yay, Australia, you have it approved for women. But, women aren't even being given the opportunity, the chance to talk about it. I mean, we're really doing a disservice. This can save marriages, restore intimacy, confidence. It's such an important part of a woman's life. And so they're just so grateful when I even bring it up. We screen every single patient in our clinic for sexual dysfunction.
It's so important to have this conversation. I wonder for you, knowing everything that you do, if there was 1 or 2 things you could tell people about menopause that you think would help them a lot, what would they be?
Don't be scared of it. It's, it can cause it will cause tremendous change in your body, but it's not all negative. But you need to, many of us have to readdress how we think of health and how we want to navigate this. And you can be healthy without hormone therapy. Absolutely. But for most women, it is harder. and it will hasten, the aging process in a lot of organ systems. So what hormone therapy does is slow down the rate of the accumulation of plaques in women, slows down the rate of our bone deterioration, slows down the rate of our muscle deterioration. And so we still have to eat the protein and do the work and lower our stress and prioritize all this, not smoke and do all the habits. But hormone therapy can be a really important tool into helping you prevent diseases or at least hold them off for as long as possible.
And people that have had cancer,
Mm-hmm.
is hormone
It
HRT
depends.
okay?
It's a nuanced conversation. I mean, all cancers, no, but cancers that could be fed by estrogen, that is a nuanced conversation. It is not an automatic no, but you need a provider who's been educated, understands the risk and benefits. One of the most devastated populations that we have are cancer survivors who are being told there's nothing we can do. Be grateful you're alive, and their quality of life is horrible. And no one is addressing that with them. They were blindsided by their menopause, which was induced for good reason. But no one is walking them through the path and being a partner with them. They're told to suck it up, go get therapy. That don't even get me started. Cognitive behavioral therapy to treat a hot flash.
Really.
I mean, talk about the misogyny and the patriarchy trying to put a boot on a woman's neck. I have CBT for trauma, for those babies that died. That is my way to treat that, but not for fucking hot flash. Changing my perception of a hot flash, give me a break.
Yeah.
A hot flash is a bell ringer for cardiovascular disease, for risk of stroke, for risk of diabetes. That is your body waving a red flag. And for you to outthink it, I think is ridiculous.
That's such wise information. I wonder, what is some of the best advice just generally in life that you have ever received?
Gosh, don't sweat the small stuff, know your own power. Whenever I'm asked, where do you see yourself in 5-10 years? I would never have dreamed I'd be here in 5 years. I'd be speaking at the Opera House in Sydney, one of the most, iconic, recognized things on a subject that I hated in medical school. But a year ago, I would have sold myself short. And so the best advice I got on that was from Jamie Kern-Lima, who said, leave it in God's hands. Write down that piece of paper. Don't make a list of all the things you want to happen. Make a list and saying, it's where God wants me to be. And I thought that was beautiful.
I wonder, do you believe in God and have faith?
I do. I do. I was raised Catholic, given, we don't really practice Catholicism anymore, although I'm still kind of Catholic, when you grow up that way. But I still have such spirituality. I absolutely believe in God, a higher power, higher than me. There's no way. Look at my children. They're miracles.
I mean, can you even believe, because it hasn't, I know that you've obviously been a doctor for very long period of time.
Since 98. Yeah, I graduated from medical school. So I've been on this process since
it's not
94.
like an overnight.
So 30 years. Yeah.
But talking about menopause and perimenopause and the things that you have spoken about, do speak about, that rise was very fast. And I always think, of course, I'm a very spiritual person. I believe in God. And I think that doesn't just happen. You know?
It really has been about 10 years.
Yeah.
So my brother died in 2015, and we're at the 10-year mark. And that is really when I realized I was menopausal. I had stopped birth control and was having horrible hot flashes and all the things. That journey began 10 years ago. My ability to speak at it, my development as a science communicator on crazy internet platforms, that kind of came more recently. But I've been on this journey doing the research, reading the papers, surrounding myself with experts, who really see patients and care about women. That's a difference than academia sometimes. And I was in academics for 20 years, so I very much know that world. And so it seems really fast, but it's been a work in progress for 10 years.
I wonder, the contraceptive pill, does that have any effect on menopause?
So we know that women who take contraceptives for long term, 10, 15 years, tends to have a little bit later, like months, not dramatically longer. But, you inhibit ovulation, you don't lose eggs quite as fast, but it's not a dramatic difference. I don't think we're counseling women on birth control pills well. I think we need contraception. We need options. But I think, birth control pills actually lower libido. They, do things that
Do
we're not
they?
counseling. Yeah, you suppress the testosterone. And
Wow.
so we're seeing, a lot of side effects. And so I was on birth control pills to treat polycystic ovarian syndrome for years and was very, very happy with it. But I'm really, and we use them occasionally in perimenopause, especially if she needs contraception or the biggest difference is dose. Contraception was developed to stop ovulation, to send that signal in a high enough level to the brain to shut it off, stop sending the, signals to the ovary. Whereas menopause hormone therapy was developed to stop a hot flash, no other reason. And so the biggest difference is dose. So we need a much higher dose to suppress ovulation and shut down the factory in the brain than we do to stop a hot flash.
Do you think being on birth control pills, like I had friends who went on it from like age 14 because they had heavy periods or whatever, some even for their skin and stuff like that. It took them a while longer to fall pregnant. Maybe that is just a coincidence. What is your research in that
So when
field
we
been?
look at the data so far, it doesn't seem to, you're just older. So
Yeah.
age, we peak fertility for females at about, somewhere between 18 and 25 is our kind of most likely time to get pregnant and stay pregnant. And then that fertility drops off because our number of eggs drop off. So if you suppress your, if you wait to have a family, which is totally reasonable because of school and careers, and think of the women who take birth control and why, then they take a little bit longer to get pregnant. But when you age match it, they don't see a huge difference.
Okay. What's something that you wish for yourself?
Oh my gosh, that my kids are happy. Because if they're not happy, I'm not happy. I'm living my best life, honestly. I never dreamed I would have this opportunity to teach and travel and feel so happy in my career. I was not happy at the end of my academic career and it wasn't the people I worked with or my patients. I adored them. It was the administrative burden, all the changes in medicine that were happening, the corporatization, the crunching of time, the multiple layers of administration that were hired to literally just tell me what to do when I was a great doctor and not let me do my job. And I stepped away from that system and developed a private practice outside of the insurance system. And I've never been happier. I'm doing wonderful, beautiful care, for patients who are so grateful and so happy. We spend an hour with every patient. She walks out with meal plans and a nutrition plan and an exercise plan and hormone therapy if she wants it, if she's a good candidate. But we really are doing this holistic plan for patients. And it's just the most beautiful medicine I've ever practiced.
That's wonderful. Do you have a favorite prayer or saying?
There, but by the grace of God go I. I don't want to judge another woman for choices that, I'm always aware. I grew up in very different circumstances than I live now. My children were raised very differently. They had they might tell you differently, but much more stable household, much less drama. I certainly have my moments, but, and I'm always reminded to not judge another, choices because I haven't stood in her shoes. So
I love that. And our final question, what is a life of greatness to you?
I think I'm living it. I'm so happy. I have wonderful relationships. I have wonderful community. I have so much opportunity to continue to grow and share and learn from people. And I think that is as great as I could ever be.
Mary Claire Haver, it has been an absolute pleasure to talk to you today, but thank you so much for bringing light to subjects that haven't been talked about for, everyone's lifetime. I mean, as you know, you are really changing the narrative and changing lives by doing that. I don't come to Sydney for meeting people, but I came for you, and I am so happy I did. So thank you so much for the conversation today.
I appreciate it, making the time for me.